Imagine for a second that you wake up one morning and your leg just feels, well, it feels different.
Mm-hmm.
It's not exactly pain, not at first anyway. It's more
Right.
of a heaviness, like gravity is pulling on that one specific limb just a little bit harder than on the rest of your body.
Right, a dragging sensation.
Exactly. You look down and it's swollen and you
Yeah.
think, okay, maybe I ate too much salt last night, or, maybe it's this heat wave.
Usual suspects.
The usual suspects. You elevate it on a pillow, it goes down a bit, you go about your life, but then weeks later, it's back. And this time, it's harder.
Right.
And suddenly, your favorite shoes, the ones you've worn for years, they just don't fit anymore.
And that's when the alarm bells start to ring.
They should. But you go to a doctor, and they might tell you it's just weight gain. You go to another, and they say it's your veins. It turns out you might be dealing with a massive medical puzzle that affects hundreds of millions of people, yet is constantly misunderstood, misdiagnosed, and, frankly, mistreated.
It is a staggering issue, isn't it? We're talking about a condition, or I should say a pair of conditions, that affects anywhere from 140 to 250 million people worldwide.
That number is it's hard to even comprehend.
It is. To put that in perspective for you, that's a population roughly the size of Brazil. And yet the average person, and surprisingly even many general practitioners, they struggle to identify it correctly.
So it's often just dismissed as swelling or, oh, you're just getting older.
Exactly. It's written off.
It's a silent epidemic. And today on the deep dive, we are tackling what we're calling the swollen truth. We are unpacking two conditions that can look like twins but are actually total strangers: lymphedema and lipedema.
And to do that, we have some fantastic source material.
We do. We're diving into a really comprehensive chapter titled The Lymphedema, which was written by three absolute heavy hitters in the field: Professor Corrado Campisi, Dr. Lucian Giga, and Dr. Zahar Jandali.
I mean, these are arguably some of the top minds in lymphatic surgery and microsurgery in the world today. What they put together here isn't just a textbook definition, it's a roadmap.
A roadmap of what, exactly?
A roadmap of the body's second circulatory system, how it fails, and the cutting-edge, almost sci-fi ways they're now fixing it. We're going to cover everything from the microscopic plumbing to the surgical rewiring of the human body.
I love that you called it the second circulatory system because that's where we have to start, right?
I think so.
I think we all learned about blood in school arteries, veins, the heart pumping. We get that. It's the A-list celebrity of anatomy. But the lymphatic system, it feels like the forgotten middle child.
It is, unfortunately, often overlooked, yes. It's a bit like the Cinderella of anatomy. It's doing all the cleaning up while the blood gets all the attention, but it is absolutely vital.
So if blood circulation is the supply chain,
Delivering oxygen and nutrients to the doorstep of every cell, yes.
then the lymphatic system is the sanitation department.
Precisely. It is the waste management infrastructure of the human body. It's the garbage disposal.
So if the lymph system goes on strike, the trash just piles up.
That's it, exactly. And the consequences of that trash piling up, that's what we call lymphedema. But before we get to the pathology, the sickness, we really need to appreciate the engineering here.
Okay.
Campisi and his colleagues, they describe it as a transport route running almost perfectly parallel to your blood circulation. It's a shadow network.
Okay, let's visualize this. We have the blood vessels. Where are the lymph vessels in relation to them? Are they inside? Outside?
They're everywhere, woven into the very fabric of your tissues. It starts with these tiny, tiny vessels called lymphatic capillaries. And what's interesting, the source notes that these capillaries are about 50 micrometers in diameter.
Which is, that sounds incredibly small. But in the world of capillaries, that's actually quite large, isn't it?
It is. It's huge for a capillary. They're actually 10 times larger than blood capillaries.
10
times. And that size difference is the absolute key to their function. You see, blood capillaries, they're designed to be tight. They're like a fine mesh sieve. They can handle water and small nutrients, but they're too tight to absorb large molecules.
And what kind of large molecules are we talking about? Like, what's the garbage?
We're talking about the heavy stuff.
Yeah.
Large proteins that leak out of the blood. Bacteria, viruses, cell debris, the wreckage from dead cells.
Right.
That stuff is just too bulky for the blood capillaries to take back up. If you tried to shove a large protein molecule back into a blood vein, it just wouldn't fit. It'd be like trying to push a basketball through a garden hose.
So the lymph capillaries are the wide load trucks. They're the heavy haulers.
Exactly. They are the heavy haulers. And they have these special structures. Think of them like swinging garage doors that open up when the pressure in the tissue rises. They absorb all the junk that the blood vessels leave behind in what we call the interstitial space.
That's the space between your cells.
The space between the cells, yes. They sweep it up and transport it away.
This source mentioned a specific number regarding the volume they move that honestly just blew my mind. We're not talking about a few drops here.
No, not at all. It's impressive. We are talking about roughly 2 to 3 liters of fluid every single day.
2 to 3 liters, so like a big soda bottle's worth of fluid?
Yeah, that's fluid that has leaked out of your blood circulation into your tissues. It's a constant physiological leak. If the lymphatic system didn't return that 2 to 3 liters back to the bloodstream, your blood volume would drop and your tissues would swell instantly.
Or you'd go into shock?
You'd go into hypovolemic shock within hours.
Wow. So it's basically bailing out the boat constantly. It's keeping us from inflating like water balloons.
Constantly. And it's not just moving water, it's a defense network. The lymph fluid travels from those tiny capillaries into precollectors, then into larger vessels, and eventually it has to pass through lymph nodes.
The lymph nodes, I think everyone knows these, usually because a doctor feels your neck when you have a sore throat. But what are they actually doing in there? What's happening inside that little bean-shaped thing?
Think of lymph nodes as security checkpoints or filtration stations. The authors describe them as secondary lymphatic organs where the immune system meets the enemy.
So the fight club of the immune system.
It's the training ground and the battlefield. The lymph vessels bring the bacteria, the viruses, or even cancer cells to the node. Inside that node, you have a standing army of B and T lymphocytes, your white blood cells. And they're just waiting.
They're on guard.
Exactly. They recognize the threat and they mount an attack.
So the source distinguishes between the primary organs like bone marrow and the thymus.
Right, that's where the cells are born and mature.
And the secondary organs like the spleen, tonsils, and these lymph nodes. That's where they actually get to work.
That's where the action is. That swelling you feel in your neck when you're sick. That's the battle raging. That's your army expanding to fight the infection.
Okay, that makes so much sense. Now, there was one other function mentioned in the anatomy section that I think people completely forget about. We've talked about fluid balance and immune defense, but there's a nutritional aspect too, right? Something about milky fluid.
Yes, this is fascinating, and it's often omitted from basic biology classes. It's the fat transport function.
Okay.
When you eat a meal that's rich in fats, lipids, your body needs to absorb them. But fats are large molecules. They can't just jump into the bloodstream easily from the gut. So there are special lymphatic vessels in your intestines called chyle vessels.
Chyle vessels. Sounds like something out of a fantasy novel.
It does. And they absorb these fats. And because of the high fat content, the lymph fluid there changes its appearance completely. Usually lymph is clear, like water, or maybe a faint yellow.
Right.
But in the gut, after you eat, say, a cheeseburger, it becomes milky turbid.
It literally turns into a milkshake inside your body.
Essentially, yes. And here is the kicker. This system allows the fats to bypass the liver initially.
Why would it do that?
The lymph carries these fats directly up the chest and dumps them into the venous bloodstream near the heart, skipping the liver's first pass metabolism. It delivers the fat directly to your adipose tissue and muscle to be used for energy or stored.
That is wild. So this system is doing 3 massive jobs at once. It's balancing fluid, it's fighting infection, and it's moving fat. It's a busy highway.
A very busy highway. And like any highway, it has traffic control. The source really emphasizes the importance of valves.
Okay.
The lymphatic vessels are lined with valves that ensure one-way traffic. They're like little one-way doors that prevent the fluid from flowing backward. It's a pumpless system, in a way.
Wait, I remember reading that. It doesn't have a heart, right?
Okay.
Blood has the heart to pump it, a centralized engine. The lymph system, what pushes the fluid? Does it just rely on us walking around?
Primarily, yes. It relies on what's called the muscle pump, your skeletal muscles, specifically in your calves and arms, contracting and squeezing the vessels.
Like squeezing a tube of toothpaste.
Exactly like squeezing a tube of toothpaste. And because of the valves, the fluid can only go one way. The vessels themselves also have a tiny bit of intrinsic muscle that creates a slow, rhythmic pulsation. But the main driver is your movement.
That explains so much. That is why when you sit on a plane for 10 hours, your ankles swell. The pump isn't working because you weren't moving.
Exactly. The Cankles phenomenon. Gravity wins because the muscle pump is turned off. The system gets sluggish.
Okay, so we have this intricate system, but there's one part of the body that says, no thanks, I'm good. The brain.
Yes, the brain is the great exception. The central nervous system is largely left out of this specific lymphatic network. The lymphatic vessels, they stop the meninges. the covering of the brain.
So the brain has its own system.
It has its own separate disposal system, often called the lymphatic system, which is a whole other deep dive for another day. But for the context of lymphedema as we're discussing it today, the brain is its own island.
Okay, so we've established the hidden highway. We know how the traffic is supposed to move. Now, let's talk about what happens when there's a pileup. When the plumbing fails, this is lymphedema.
The definition provided by Campisi and his team is straightforward, but devastating. Lymphedema is a lack of transport capacity.
Simple as that. The pipes can't handle the flow.
The plumbing cannot keep up. The result is that interstitial fluid, that fluid between the cells, builds up, can't leave. So you get visible swelling, but you have to remember it's not just water.
Right, it's the garbage we talked about.
The proteins in the cell debris, the toxic stuff.
And that's bad if it just sits there.
Exactly. That protein-rich fluid is very bad for tissues. It causes chronic inflammation. It causes fibrosis, which is a hardening of the connective tissue. The soft, pliable skin becomes hard and wood-like over time.
And it also, too, there's more fat storage?
Yes, interestingly, this inflammatory soup actually signals the body to store more fat in that area.
So lymphedema isn't just fluid. It actually changes the structure of the limb. It's not just a water balloon. It becomes a brick.
It fundamentally alters the tissue architecture. It becomes a mix of fluid, scar tissue, and pathological fat.
The source breaks this down into two main types, primary and secondary. Let's start with primary. This is the one you're born with.
Correct. Or at least the potential is there from birth. Primary lymphedema is congenital. It's rare, so it represents the minority of cases. Essentially, the person is born with a malformation. It's called hypoplasia of the lymph vessels.
Like having a highway with only one lane instead of four?
Or a highway that just dead ends, or you just don't have enough vessels. Or the vessels you have are huge and floppy, so the valves don't close properly.
And is it hereditary?
Interestingly, the source notes that 97% of these cases are sporadic. They aren't inherited from your parents. They just happen during fetal development.
And it hits women more?
Twice as often as men. And here's the cruel part. It usually manifests at puberty.
Oh, that's brutal.
It is. So you have a young teenager, 13 or 14 years old, going through all these hormonal changes, trying to fit in, and suddenly one of their legs starts to swell. You could just imagine the psychological impact.
Absolutely. But the much bigger group, the one that makes up those hundreds of millions of cases, is secondary lymphedema. This is acquired. This is, you had a working system and something broke it.
Yes. This is the common form. Now, if we look globally, the number one cause is actually a parasite.
A parasite. That feels very medieval.
It does, doesn't it?
Yeah.
It's called lymphatic filariasis. It's caused by a nematode worm, Leucorrhea bancrofti, that's transmitted by mosquitoes. The worms literally live in the lymph nodes and physically block them.
Wow.
It's a massive problem in the tropical regions, causing severe elephantiasis. But in the Western world, in our latitudes, the main cause is very, very different.
It's cancer treatment.
Specifically, the surgery and radiation used to treat cancer. The most prominent example is breast cancer, but it happens with melanoma, gynecological cancers, prostate cancer, really anything where lymph nodes are removed.
This is a really important point for our listeners. We often hear about the battle with cancer and the survival rates, which is fantastic. But we don't always hear about the aftermath. Explain the connection. Why does saving a life sometimes cost a limb?
It's a matter of checking for spread. When a surgeon removes a tumor from the breast, they have to check if the cancer has traveled. And the first place breast cancer usually spreads is to the lymph nodes in the armpit, the axilla.
So they have to take them out to check them.
They perform what's called an axillary dissection, or lymphonoidectomy, which basically means removing those lymph nodes to analyze them under a microscope.
They're removing the filtration station.
They are removing the station and cutting the highway that leads to it. The lymph fluid from the arm usually drains through those armpit nodes. If you remove them, the fluid from the arm hits a dead end at the shoulder. It has nowhere to go.
And the source gave some specific stats on the risk here. It varies depending on how aggressive the surgery is, right?
It does. If they do a radical removal of nodes, taking out a large cluster, the risk of developing lymphedema in that arm ranges from 9% to 41%.
41%, that's nearly half of patients in some studies.
It's a huge risk. Now, if they do the newer, less invasive sentinel node removal, where they map and remove only the first 1 or 2 nodes that drain the tumor, the risk drops to about 4% to 10%.
Better, certainly, but still not zero.
Not zero.
And there's this concept of the ticking clock that I found really scary. You don't wake up from surgery with a swollen arm immediately.
No, and that's what makes it so insidious. The average onset is about 8 months after the surgery. but it can happen years later. The source states that 75% of cases appear within the first 3 years.
So you think you're in the clear, you think you've beaten the cancer, you're moving on, and then one day your ring feels tight.
Exactly. Or you get a mosquito bite on that arm, and it suddenly just balloons.
Why the delay? Why doesn't it flood the moment the pipe is cut?
The body tries to compensate. It's incredibly resilient. It tries to force fluid through side roads, tiny collateral vessels. It revs up the remaining system to 110% capacity.
But eventually it just gets overwhelmed.
Eventually those side roads get overwhelmed. Or maybe a minor injury or an infection adds just enough extra fluid to tip the balance. Once that transport capacity is exceeded, the swelling begins.
And once it starts, it goes through stages. Campisi and the team outline these very clearly. Stage 0 to stage 3. Let's walk through what these look and feel like, because early detection is everything. Stage 0 is latency.
Stage 0 is invisible. You have no symptoms. The arm or leg looks completely normal. But if we were to look with specialized equipment, we'd see the flow is already slowed, the system is struggling, but it's keeping its head above water barely. It's a subthreshold edema.
Then comes stage 1.
Stage I is the reversible stage. This is key. The swelling is soft, it's doughy. You press your thumb into your shin, it leaves a dent. That's called pitting.
Right.
And crucially, if you elevate the limb, lift your arm or leg up on a pillow overnight, gravity helps drain it, and the swelling goes away. You wake up with a normal limb.
So it fluctuates. You wake up with a normal leg, it swells during the day, you sleep with it up, and it's normal again in the morning.
Exactly. But if it's left untreated, those proteins we talked about, they start to cause inflammation and scarring. And that progresses to stage 2.
Okay, what does that look like?
Now we see fibrosis. The tissue hardens. Elevation doesn't help anymore because the fluid is trapped in this honeycomb of scar tissue. You can't press a dent into it easily because the tissue is becoming like a dense sponge that's filled with glue.
And finally, stage 3.
This is often called elephantiasis. It's the maximum expression of the disease. Massive swelling, severe hardening, and significant fat proliferation. The skin changes texture. It gets bumps, warts, what they call papillomas, eczema. Movement becomes severely restricted. It's a terrible burden on the patient, both physically and socially.
It sounds horrifying. So how do doctors figure this out before it gets to stage 3? We're on to the detective work section of the source.
History is the first clue. As
Yeah.
we said, asking about past surgeries, infections, family history. But physically, there's a very specific field test mentioned in the text that everyone can try. Though hopefully for you, it's negative. It's called Stemmer sign.
Stemmer sign? How do we do it? Can our listeners try this?
If you can reach your feet, yes. Go to the base of your second toe, the one next to the big toe. Or you could do it on your second finger. Try to pinch and lift a fold of skin there. Imagine you're trying to pinch a little tent of skin at the very base.
Okay, I'm doing it on my finger. I can pull the skin up easily. It's loose.
That is a negative Stemmer sign. That's normal. In lymphedema, because the tissue is so full of pressurized fluid and that fibrosis we mentioned, you cannot lift that skin. It feels thick, taut, and just stuck down.
So if you can't pinch and lift the skin at the base of the toe, that's a positive Stemmer sign.
And it's a very, very strong indicator of lymphedema.
So a negative sign doesn't mean you're 100% clear, but a positive sign is a smoking gun.
Correct. But modern medicine doesn't just rely on pinching toes, of course. We have high-tech imaging now, and the source highlights something called ICG lymphangiography.
Indocyanine green. This sounded like a rave party to me when I read the description. It involves a glowing dye.
It basically does. It's an absolute game changer. They inject a tiny amount of a fluorescent dye into the skin, usually between the toes or fingers. And this dye is special because it's picked up specifically by the lymph vessels. Then they use a special infrared camera to watch it.
So you can see the highway in real time.
You can. On the screen, healthy vessels look like these distinct, bright, linear streaks, like a flowing river of starlight. But in a diseased limb, you see something very different. You see dermal backflow.
What does that look like? A traffic jam?
It looks more like a cloudy swamp. Or sometimes like a fireworks explosion where the dye is just leaking all over the place because it has nowhere to go. It spreads out into the skin instead of moving up the vessel. It allows the surgeon to map exactly where the blockages are.
That is incredible. It makes the invisible visible. So you've got the diagnosis. You see the swamp on the screen. Now, what do? The source talks about the gold standard treatment called CPD.
CPD stands for Complex Physical Decongestive Therapy. And I want to emphasize that word complex. This is not just taking a pill. It's a regimen. It's a lifestyle overhaul.
It sounded like a full-time job when I was reading it.
It can feel like one for the patient, yes. It has 2 phases. Phase 1 is decongestion, getting the fluid out. Phase 2 is maintenance, keeping it out.
Okay, so phase 1, how do we get the fluid out?
It rests on 4 pillars. First, manual lymphatic drainage, or MLD. This is a very specific type of massage. It is not a deep tissue muscle massage. It's very light, rhythmic stretching of the skin to stimulate those lymph vessels to contract and push fluid away from the blockage and toward healthy areas of the body.
Pillar 2.
Compression. And this is crucial. You wear multi-layer bandages, and you wear them 24/7, taking them off only for the massage and for showers.
Oof. 247. That's intense.
It creates a rigid casing. Think of it this way. When your muscles contract, they usually bulge outwards. But if they're wrapped in a rigid bandage, they can't bulge out. So the force is directed inward, squeezing the deep vessels and pumping the fluid up.
Pillars 3 and 4.
Skin care and exercise.
Right.
Skin care is vital because, as we noted, the skin barrier is compromised. A tiny crack can let bacteria in, leading to a serious infection called erysipelas.
Right.
And exercise, of course, activates that muscle pump we talked about earlier.
Then, once the limb shrinks down as much as it can, you enter phase 2, maintenance.
Right. Now, you switch from the bulky bandages to compression stockings,
Yeah.
but not the ones you can just buy at the drugstore. The source is very specific. You need flat knit stockings.
What's the difference? Why does the knit matter so much?
It's a huge difference. Most stockings are circular knit. They're made like a seamless tube, like a sock. They're stretchy and elastic. They're fine for varicose veins, but for lymphedema, they're often too soft. They can cut into skin folds.
And flat knit.
Flat knit is custom made. It's knitted as a flat sheet and then sewn together so it has a seam. The fabric is coarser and much stiffer. It has high stiffness, meaning it doesn't stretch easily. It holds the limb in like a cast, preventing the swelling from rebounding.
That's the hard reality then, lifelong compliance. And here is where it gets really interesting. What if you don't want to wear a bandage forever? What if you want to fix the plumbing? This is where Campisi and his team really shine. We're entering the surgical revolution.
This is truly the frontier of the field. For a long time, surgery was seen as a last resort, or even dangerous. Doctors used to say, don't touch it, you'll just make it worse. But super microsurgery has changed everything.
And the authors describe restorative surgery actually rewiring the body.
That's right.
There are a few methods here. Let's start with the bypass.
The lympholymphatic bypass. Imagine a blocked highway. They take a healthy lymphatic vessel from a different part of your body, say your leg, and use it to build a bridge over the blockage in your arm. It literally bridges the gap, allowing fluid to flow over the destroyed area.
But the one that really caught my eye was the LVA, or MLVA, the microsurgical detour.
Lymphovenous anastomosis. This is brilliant engineering. Instead of trying to send the lymph all the way up the arm to the neck where it usually drains, the surgeon asks, why drive to the city dump when you can use the local drain?
What do you mean by that? How does that work?
They find a tiny, tiny blockage point. They find a lymphatic vessel right there in the swollen arm, and they connect it directly to a tiny nearby vein. They shunt the lymph fluid into the bloodstream locally.
So they're just dumping the fluid into the bloodstream right there in the arm instead of sending it all the way up.
Exactly. They create a shortcut. Campisi's specific method involves connecting multiple lymph vessels into a single vein site, a single-site MLVA.
And we are talking about sewing vessels that are fractions of a millimeter wide.
Oh, yes. The source mentions using 50x magnification microscopes and hair-thin threads. Actually, the threads are thinner than a human hair. It requires incredible skill. But the results? Subjective improvement in up to 95% of patients.
95%.
It can reduce the need for those heavy garments significantly, sometimes even eliminate it.
That is life-changing. There's one more restorative technique that sounded a bit bizarre but fascinating. The sponge. Vascularized lymph node transfer.
This is where they take a package of healthy lymph nodes with their blood supply from a donor site. Jan Dali, one of the authors, he prefers taking them from the stomach area, the greater omentum, because it has less risk of causing lymphedema there compared to taking them from, say, the groin.
They take nodes from your belly and they put them in your armpit.
Yes, they connect the blood vessels so the nodes stay alive. And these transplanted nodes, they do two things. One, they act like a biological sponge, sucking up excess fluid and dumping it into the veins.
And two,
And this is the magic, they release growth factors, like something called VEGFC, that stimulate new lymphatic vessels to sprout.
it's like planting a seed that grows a new root system. It's biological terraforming.
It really is. It regenerates the entire network from within.
Now, there's a preventative angle, too, the Lim-MPHA principle. This is about fixing the problem before it even starts, isn't it?
This is arguably the most important advancement for cancer patients. The idea is, why wait for the arm to swell? When the cancer surgeon is removing the nodes, a plastic surgeon steps in right then and there during the same operation.
Okay.
They find the lymph vessels that have been cut, and they immediately connect them to veins.
So they're fixing the plumbing while the wall is still open?
Exactly. It adds maybe 30 minutes to the surgery, but it significantly reduces the risk of lymphedema ever developing in the first place. It's proactive rather than reactive. It's changing the standard of care.
I love that. Now, we have to talk about the debulking surgeries. Sometimes limb is just too big, there's too much fat and fibrosis, and microsurgery won't fix that bulk because the tissue is already changed. So, liposuction. But wait, Campisi warns us, this is not cosmetic lipo.
This is a crucial distinction. Standard cosmetic liposuction is blind. You stick a cannula in, and you suck out fat to contour the body. If you do that to a lymphedema patient, you will likely tear apart whatever functioning lymph vessels they have left.
You'd destroy the remaining highways.
And make the transport problem infinitely worse.
So what do they do instead?
They use lymph vessel-sparing liposuction. They use that glowing ICG dye we talked about to map the vessels during the surgery. They can literally see where the lymphatics are and avoid them, only sucking out the fat and the fibrosis around them. Campisi calls it fibrolipolymph aspiration.
A mouthful, but a safe mouthful.
And he emphasizes that this is usually done after the microsurgery has fixed the flow. First you fix the plumbing, then you clean up the flood damage.
And then there's the nuclear option, the Charles procedure.
This is reserved for the most extreme cases. Severe elephantiasis, where the skin is ruined, covered in warts, ulcers, and it's constantly leaking fluid. The Charles procedure involves literally skinning the leg.
Skinning it.
They remove all the skin and the subcutaneous tissue right down to muscle fascia. Then they cover the muscle with skin grafts.
It sounds medieval.
It is radical. It looks, well, it's functionally better because the weight is gone and the infection risk drops, but cosmetically is not pleasing. It looks like a peg leg covered in grafts. It's a salvage procedure, really, when all else has failed.
Okay, so that's the landscape of lymphedema. Broken plumbing, fluid buildup, microsurgery fixes. But now, we have to meet the imposter.
Lipedema.
It sounds the same. Lymphedema. Lymphedema. Just one letter different. But the source makes it very, very clear they are fundamentally different diseases.
They are. And the tragedy is that lipedema is constantly misdiagnosed as lymphedema, or even worse, just simple obesity. Women are told for years, stop eating cake and go to the gym when they're actually suffering from a disease.
Let's define it. What is lipedema?
It is a pathological proliferation of fatty tissue. It's not a fluid buildup, at least not initially. It is the fat cells themselves growing uncontrollably and pathologically.
And who gets it?
This is the starkest difference. It is a female disease. It affects almost exclusively women. Men practically never get it unless they have severe hormonal imbalances or liver damage.
So hormones are the trigger.
It seems likely. It usually starts at puberty or during pregnancy or at menopause, periods of major hormonal flux.
Okay, I'm a listener. I have swollen legs. How do I know if it's lymphedema or lipedema? The source provides a brilliant showdown tech list. Let's run through the rapid-fire comparison so listeners can spot the difference.
Let's do it.
Point 1, gender.
Lipedema is women only. Lymphedema affects both men and women.
Point 2, symmetry.
Lipedema is always symmetrical. Both legs look the same. They act in unison. Lymphedema is often asymmetrical. One leg is big, the one with the removed nodes or the defect, and the other is normal. Or at least one is much bigger than the other.
Point 3, the hands and feet. This is a big visual clue.
A huge clue. In lipedema, the swelling stops dead at the ankles or the wrists. It creates a cuff or a bracelet effect. The feet look completely normal.
And lymphedema.
In lymphedema, the fluid goes all the way down. The tops of the feet often resemble a rising loaf of bread.
Point 4, Stemmer's sign.
Remember the toe pinch. In lipedema, the Stemmer's sign is negative. You can pinch the skin on the toe because the feet aren't swollen.
And lymphedema is positive.
Correct.
Positive.
Point 5.
Texture. How does it feel?
Lipedema feels soft, doughy. If you run your hands over it, you might feel little knots under the skin, like beans in a bag or styrofoam balls. Lymphedema in the later stages feels hard, woody, fibrotic.
Point 6, the pain.
This is the heartbreaking differentiator. Lipedema is painful. The fat itself hurts. It is sensitive to touch and pressure. Women often say their cat walking on their lap hurts, or if their children sit on their legs, they have to push them off.
And lymphedema isn't painful in the same way?
Lymphedema feels heavy or tight, a sense of tension, but it rarely hurts in that direct bruising way.
Speaking of bruising, point 7.
Lipedema patients bruise very easily. You bump into a table, you get a massive hematoma. The capillaries are just very fragile within that diseased fat. Lymphedema patients don't have that specific fragility.
Okay, point 8. Infection risk.
High in lymphedema, that erysipelas is common, low in lipedema.
And point 9. The cut test.
This is from the surgeon's perspective. It's fascinating. Campisi notes that when he cuts into a lymphedema leg, water literally weeps out of the wound immediately. It's wet.
And lipedema.
In 15 years of operating on lipedema, he says he has never seen a single drop of water leak out. It's dry fat.
That is such a vivid image, dry fat versus wet fluid. And finally, point 10, response to treatment.
Manual lymphatic drainage, the massage, it works for lymphedema. It does not work for lipedema.
Why not?
Because the problem isn't fluid transport, it's fat growth. You can't massage away fat cells.
That is so important. So many women are probably paying for these expensive massages that aren't doing anything at all for their condition.
Exactly. For lipedema, the only way to remove the tissue is liposuction. Again, the vessel-sparing kind is safer, or weak management. Though I have to add, lipedema fat is notoriously resistant to diet and exercise.
What do you mean?
You can lose weight in your face and your torso until you are skeletal, but the lipedema legs remain disproportionately large.
It's stubborn fat on a pathological level.
Precisely.
Now, just to make things complicated, the source mentions mixed forms. You can actually have both.
You can. It's called lipolymphedema. Essentially, if the lipedema fat grows and expands enough, it can physically compress the lymph vessels that are running through it.
It crushes the highway.
Crushes the highway. So then you get a secondary fluid buildup on top of the pathological fat. The feet start to swell. The stemmer sign becomes positive. The symptoms begin to mix.
So that's when it gets really tricky to treat because you're fighting two enemies at once.
Exactly.
And phlebolymphedema, what's that?
That's when you have bad veins. Varicose veins, venous insufficiency. The blood backs up in the veins, it leaks more fluid than usual into the tissues, and it simply overwhelms a healthy lymph system. Everything is connected.
It really is. So let's wrap this all up. We've unpacked a lot. We have the hidden highway, the sewage backup that is lymphedema, the amazing rewiring surgeries, and the painful fat imposter, lipedema.
The biggest takeaway for me is the absolute importance of a correct diagnosis. We cannot just treat swollen legs as a generic symptom. We have to know why they are swollen.
Right, because if you treat lipedema with massage, you're wasting time and money. If you treat lymphedema with standard blind liposuction, you're causing irreversible damage.
Precision matters. And awareness matters.
Okay.
If you're listening to this and you recognize yourself or maybe a friend in the description of lipedema, the pain, the easy bruising, the cuff at the ankle, don't let a doctor just tell you to eat less. Advocate for a real diagnosis.
And if you're a patient facing cancer surgery, ask about the lymph nodes. Ask about the risks. Ask if preventive LAMPHA surgery is an option at your hospital.
Knowledge is the first step to managing these chronic conditions.
I want to leave our listeners with one final, slightly provocative thought that came from the end of the source material. It's about the relationship between fat and lymph.
Ah, yes. The new research suggesting that the expanding fat cells in lipedema might actually produce factors that damage the lymph vessels over time.
It's not just that the fat is sitting there physically crushing the pipes. It might be chemically attacking the plumbing.
It suggests that what we call pure lipedema might just be the precursor to a lymphatic collapse that we haven't fully understood yet. It blurs the line between the two diseases even further.
So are they really two separate diseases or just two stages of the same fundamental failure?
A sobering thought, but one that shows just how much more we have to learn.
Next time you look at a swollen ankle, remember, there is a whole world of biology, plumbing, and warfare happening right under the skin.
Indeed.
Thanks for diving deep with us today. We'll see you on the next one.